are rare in the life-threatening situation, occur usually 1 in 2,000 pregnancies. There are certain risk factors in which if patient have these risk factors, they are more prone to develop the silent symptoms. In these silent symptoms take the patient towards the maternal collapse or the cardiac arrest. How can we define the cardiac arrest? Cardiac arrest is defined as an acute event involving the cardiorespiratory system and the central nervous system, resulting in a reduced or absent conscious level and potentially cardiac arrest and death at any stage in pregnancy and up to 6 weeks after birth. If this condition or the maternal collapse occur as outpatient, so we can't see the signs and symptoms which take the patient towards the maternal collapse, but the patient is admitted in hospital or you are observing the patient, if the patient is on follow-up, so you can see there are certain signs and symptoms are changes if you observe these patients, because these patients are certain risk factors can develop the maternal collapse, like patient may have some cardiorespiratory or something like eclampsia, history of pregnancy-induced hypertension, hyperlipidemia, some connective tissue disorders. So there are certain scores through which we can detect these signs and symptoms in these patients. Different hospitals had made different scoring charts for that. The two famous scores are the MUSE and the NEWS. The modified early warning score, the MUSE. The MUSE detect the deterioration in simple physiological signs will precede significant clinical deterioration, and that early intervention will reduce the morbidity. These scores are used in the acute settings and the critical care departments. In the UK, it is recommended by NICE and the MDES. MDES is the mother and baby. It is basically reduce the risk and of the audit and confidential inquiries in UK. Many hospitals develop their own news. It's basically are scores which have certain parameters which can detect the risk in these patients who can develop the maternal collapse or the cardiac arrest. That is called MUSE. The MUSE usually used in the patient after 20 weeks of pregnancy, because after 20 weeks of pregnancy, mostly the physiology of the pregnant ladies has been changed. And before 20 weeks, you usually use the NEWS, the National Early Warning Signs. This is the modified early warning signs or the MUSE. The MUSE has certain parameters. If you see in this slide, the MUSE has certain parameters like respiration, oxygen saturation, systolic blood pressure, pulse, and the patient response. Either the patient is alert, verbal response, response on pain, or the patient is unresponsive. These parameters has some score. You see from the center it has 0. Usually the patient in the 0 line has his patient is alert, the patient temperature is normal, pulse within normal limits, saturation is normal. The usually is BP on the maximum limit. If we sum up all the score of the patient, and sum up the score of these parameters, you will see if the patient if the patient score comes with 1 is to 3, any 1 to 3, the patient consider increased frequency of observation, inform the nurse in charge. Normally, the patient has low score. If the patient has medium score, it means the minimum score within the range of 4 or 5. It means the concerns increase. We have to inform the nurse in charge, contact the junior doctor to review the patient within 30 minutes again. If unable to attend, contact the senior doctor. In addition, you must inform the critical care outreach team, initiate treatment and document all news score and any action which the patient may have to do. Continue to monitor the patient, observe the patient every 30 minutes till the news score comes below 4. If no improvement in news score, seek senior medical review. If the patient score comes above 6, it means the patient needs acute management. You have to inform the nurse in charge, immediate call to the critical care outreach team, immediate call to the junior doctors, immediate call to the patient specialist registrar consultants and the senior anesthetists or obstetrician, review within 1 hour, initiate treatment, and document all news scores and any action taken. Continue to monitor the patient observation every 30 minutes until news comes below 4. Consider transfer to high care level if the score doesn't come below 6. If you see there are certain uh, pain assessment, choosing assessment, no pain, mild pain, the facial expressions, and which is showing the facial expression on moderate pain or the severe pain. These are the scores or the parameters which help in detection the chance of or risk of maternal collapse in the patient. This is the national early warning score we use commonly in patients who are pregnant with less than 20 weeks of gestation. It is also supported by the NHS in England. There are certain risk factors or causes which are responsible for the cardiac arrest in pregnancy. Some are obstructive causes which are associated with the Till now, we have discussed the definition of the maternal collapse and the score. So, can we assess the seriousness of the patient with maternal collapse? Again, we have to see the definition: an acute event involving the cardiorespiratory systems and the central nervous system, resulting in a reduce of the absent conscious level and potential cardiac arrest and death at any stage of pregnancy up to 6 weeks after birth. These are the two scores, the MUSE and the NEWS. MUSE is used in patients after 20 weeks of pregnancy, and the NEWS is the score we usually use before 20 weeks of pregnancy. These score has certain parameters like respiration, saturation, systolic blood pressure, pulse, responsiveness of the patient, and temperature. After the sum up of these parameters, we categorize the patient in low, medium, and high risk. Low patients are those who needs further observations, and the medium category, the patients included in this category are those who needs frequent observation after each 30 minutes, and the information or the call given to the cardiac arrest team and the senior and the junior doctors. The patient who retain the highest score, in this you have to give the immediate call to the critical care outreach team, immediate call to the junior doctors to review the patient within 30 minutes, inform the patient specialist registrar consultants, ensure the senior review within 1 hour. Within 30 minutes, the junior doctor opinion, and within 1 hour, the senior doctor. Initiate the treatment and document all the news scores and any action you have taken for this patient. Continue to monitor the patient and observe after every 30 minutes until this new score will go below 4. Because the score comes above 4, it means the patient is at high risk of developing maternal collapse. There are certain causes which are responsible for taking the patient into cardiac arrest. We categorize or divide these causes into two categories: the obstetric causes relating to pregnancy and the non-obstetric causes. Non-obstetric causes are anesthesia complications, aortic dissection, as it occurs in some connective tissue disorders like Ehlers-Danlos syndrome, bleeding, non-uterine due to some systemic disorders, cardiac disease, acute coronary syndrome, myocardial infarction, certain cerebrovascular accidents due standard to some other disease, disseminated intravascular coagulation, sepsis, and thrombosis. There are certain causes which are relating directly to the pregnancy. These include the hemorrhage, the amniotic fluid embolism, pregnancy-induced hypertension, the complication of which is eclampsia and preeclampsia, and HELP, magnesium toxicity, the postpartum hemorrhage, the uterine myotomy, and the peripartum cardiomyopathy. Hemorrhage. Hemorrhage means the antepartum hemorrhage and the postpartum hemorrhage. Both leads to the patient towards the maternal collapse. Maternal collapse secondary to APH. The fetus and the placenta should be delivered to allow the control of hemorrhage. Because there is an abruption of the placenta, there is a massive flow of blood, and this is critical both for the mother and the fetus. In case of massive placental abruption, cesarean section may occasionally be indicated even if the fetus is dead. Usually in dead fetus, we try to deliver the patient vaginally, but if the bleeding is massive and the patient has a huge placental abruption or the whole of the placenta is abrupt, there is a need to go for cesarean section or termination of pregnancy. Because in this patient, the patient may go in DIC. If the patient is in DIC, the coagulation cascade system will be failed, and there will be a condition comes when patient will go towards the maternal collapse. So we have to allow the rapid control of hemorrhage by doing the cesarean section or by doing hysterectomy or any other method. Just like hemorrhage, there is a postpartum hemorrhage. In postpartum hemorrhage, same thing happens. There is a massive loss of blood. There will be a cardiorespiratory failure. The patient will go in shock due to this heavy bleeding. Amniotic fluid embolism. Amniotic fluid embolism usually occur 1 in 1,000 pregnancies and hemorrhage 1 in 6,000 pregnancies, but these incidences are from the youth. The average incidence is higher than this. Amniotic fluid embolism. Amniotic fluid embolism when the amniotic fluid or the debris from the uterine cavity enters into the maternal circulation. It will cause vasoconstriction or the pulmonary hypertension of the dead. Pulmonary hypertension patient may go in right ventricular failure. There will be a coagulopathy and there is chance of thromboembolism. So this amniotic fluid embolism The mechanism should be supportive rather than specific, as there is no proven effective therapy for amniotic fluid embolism. Early involvement of the senior experienced staff, including the obstetrician, anesthetist, hematologist, and intensivist. If we are treating these high-risk pregnancies, then we should have a multidisciplinary approach involving the senior obstetrician, senior anesthetist, senior pediatrician. If we have some problems of coagulopathy, then we should involve the hematologist and intensivist. Coagulopathy needs aggressive management, including the blood products like PCVs, FFPs, or platelets. Recombinant factor 7. It's need only when the coagulopathy cannot be corrected by the massive blood component replacement. Cardiac disease. Cardiac disease is another entity in which the patient may go in maternal collapse. After resuscitation, cases should be managed by some cardiology team, but if we are treating the patient, we should involve the cardiologist if patient has maternal collapse. Sepsis. Sepsis is another condition which may be a sequel of septic abortion, may be a sequel after intrauterine death. In the case of sepsis, again, we should have a multidisciplinary approach. We should send the investigation, especially the serum lactate. We should send the blood cultures, high vagina swab, giving swabs of culture and sensitivity. We should start the broad spectrum antibiotic. If patient has hypotension, the lactate is more than 4, it means the patient is going into septicemia, septic shock, or multi-organ failure. So we have to give the rapid administration of 30 ml per kg of crystalline to be completed in 3 hours of diagnosis to prevent that hypotension. We should provide patient drops to keep mean arterial pressure above 65 and remove the septic foci. Patients sometimes have drug toxicity. In pregnancy, the drug toxicity is mainly due to two things: the magnesium sulfate or the toxicity after giving local anesthetics. Local anesthetics in the form of local infiltration or for the local anesthesia provided for the regional anesthesia like epidural or spinal anesthesia. If patient has magnesium toxicity occurs when we give patient magnesium sulfate in case of preeclampsia or eclampsia to prevent the fit or further therapeutic purpose. The antidote of the magnesium sulfate is calcium gluconate. 10 ml, 10% calcium gluconate. You have to give it slowly to prevent sudden cardiac arrest. The magnesium sulfate has replaced all body calcium. So there are certain signs and symptoms which will show that patient has magnesium toxicity like respiratory depression, reflexes will be slow, diminished, or the urine output will be decreased. After that, if the concentration of the magnesium has caused certain limits like it's more than 35 millimoles, the patient may have cardiac arrest. There are certain local anesthetic agents which are responsible. Sometimes the toxicity occur may end up with maternal collapse. So if there is a reaction of some drug or drug toxicity, we have to stop that drug immediately. Anaphylaxis reaction. Anaphylaxis reaction may be by some antigen भी हो सकता है. It's after some antigen by after blood. The causative agent should be removed. Treatment is providing 1:2000 at any 500 microgram IM. Adjuvant therapies are chlorpheniramine and hydrocortisone. Mainly in anaphylaxis reaction, patient respiratory system is affected. This diagram is showing the common causes of maternal collapse. It is seen that eclampsia, the complications of eclampsia, cerebral, it affects all the organs, like affects the pain, it causes the cerebrovascular accident, it affects the heart, the patient may end up with myocardial infarction, cardiomyopathy, it affects the liver capsule ruptures, it may affect the kidney, it causes acute renal failure, it affects the respiration, it causes pulmonary edema. Anaphylaxis reaction occur, so it affects usually the respiratory systems. Other parts of the body, the skin and the changes in the skin and the mucous membrane, but there will be a respiratory depression. Mucus secretion increase when there is a vasoconstriction. It also shows the aortic dissection. After connective tissue disorders, the aorta may dissect and patient will go in myocardial collapse. Cardiac causes may arrhythmias, myocardial infarction, pericardium cardiomyopathy, certain electrolyte imbalance like hypokalemia, hyperkalemia, hypoglycemia sometimes cause hemorrhage in the form of splenic artery rupture and hepatic rupture after eclampsia and uterine ruptures after antepartum hemorrhage, uterine rupture due to previous scar, trauma during the cause of postpartum hemorrhage, trauma after instrumented deliveries. Um, these are the causes. For the ease to learn, we divide these reversible causes by the mnemonics 4H and 4Ts. The 4H, hypovolemia, hypoxia, hypokalemia or other electrolyte disbalance, or hypothermia. Hypovolemia usually occurs in pregnancy after bleeding. This bleeding may be concealed or may be revealed. Or relative hypovolemia due to spinal block, septic shock, or neurogenic shock. Hypoxia. Pregnant patient can become hypoxic more quickly because of the physiological changes which occurs in pregnancy. We will see later on what physiological changes occur in pregnant women, which makes the pregnant patient prone to develop cardiac arrest in pregnancy. Certain cardiac events which leads to hypoxia like peripartum cardiomyopathy, myocardial infarctions, aortic dissections, large vessels, aneurysms. 4 T's, thromboembolisms, toxicity, tension pneumothorax, and tamponade, cardiac tamponade. Thromboembolisms, it's not very common, but it's rare, but it's common in pregnancy, like thromboembolism with amniotic fluid embolism, pulmonary embolus, air embolus, and myocardial infarction. Toxicity, as we discussed, local anesthetic, magnesium sulfate, tension pneumothorax following trauma, the suicide attempts, road traffic accidents, tamponade following trauma, road traffic accident, or the suicidal attempts. So the least likely, but it can happen. Eclampsia and pre-eclampsia include the intracranial hemorrhage, as we discussed in cerebrovascular accidents. What physiological changes of pregnancy that affect resuscitation or make resuscitation difficult in pregnant women? Cardiovascular system. In cardiovascular system, some parameters are increased and some are decreased. The plasma volume or the blood increased by 40 to 50%, means it becomes doubled. Cardiac output by 40%. 10% of cardiac output goes towards the uterus. Heart rate or heartbeats increases 15 to 20 beats per minute. Clotting factors susceptible to thromboembolism like protein C, protein S will be increased. There will be a dextro rotation of the heart. Heart slightly moves towards seems towards right side of the chest. Slight estrogen effect on myocardial receptors. What parameters change? The supine blood pressure and venous return with aortocaval compression due to the weight of the gravid uterus. The venous return will be decreased, and the patient has supine position, and there is an aortocaval compression due to the gravid uterus. There will be a delay in the venous return. Arterial blood pressure by 10 to 15 mg. Systemic vascular resistance decrease. Peripheral vasodilation. Colloid oncotic pressure will decrease, and pulmonary capillary blood pressure. In the respiratory system, the respiratory rate will increase, and oxygen consumption increases by 20%. Tidal volume, unit ventilation, laryngeal angle, there will be a pharyngeal edema and nasal edema. Functional residual capacity of the lungs decrease by 20%. The PCO2 will decrease due to hyperventilation and serum bicarbonate. What happens with gastrointestinal symptom? The peristalsis and the gastric motility will be decreased. The gastroesophageal sphincter tone will be decreased due to the effect of hormones, estrogen and progesterone. Basically, the progesterone. Like what happens about changes occur in the uteroplacenta? Due to placental blood flow increases by 30% of cardiac output, 10 to 30%. Aortocaval compression, elevation of the diaphragm by 4 to 7 centimeters. Auto-regulation of blood pressure will be decreased. Breast, the size of the breast will be increased and it will decrease the chest wall compliance. Renal compensated respiratory alkalosis, renal alkalosis, ureter dilatation, especially on the right side, and delay in the bladder emptying. Resuscitation, how will you go for resuscitation in case of maternal collapse? We will follow the standard KBCT approach according to the Resuscitation Council UK guideline. This is the maternal collapse algorithm, which shows how can we treat the patient. The patient has come with the patient developed maternal collapse. We have to keep the patient in the safe environment where we can proceed with the measures. Stimulate and assess the patient response. If the patient is responsive, then we ensure the manual U-point displacement or slight left lateral tilt of the patient. To decrease the pressure from the vena cava, we should give the call for help, assess the patient vitals like breathing, pulse, blood pressure, and the fetal heart rate. Regular assessment of the patient using the Muse chart, identify the cause of the collapse and direct the treatment towards that cause. If the patient has no response, shout for help or call to the resuscitation team. A, B, C, D, E. A means airway. We have to open the airway. Check for obstruction, head tilt, and chin lift. Then we assess the breathing pattern for up to 10 seconds. Look for the chest movement and listen for the breath sounds. Feel for the air. If no breathing, start CPR. We have to give the chest compressions because this is the algorithm for the maternal collapse. It's a teamwork. And in the team which will treat the patients with maternal collapse, have the senior obstetrician, senior anesthetists, the porters, the junior doctors, the staff nurse, the midwives, all will be there. And the two persons to change their duties for the CPR. If one is providing 30 chest compression after 2 ventilations, the rate should be 100 to 120 chest compression per minute. The depression of the chest compression, the 5 to 6 centimeter at the center of the chest. I will show you the diagram. This slide is showing how to relieve the aortocaval compression. Then we will again come towards the algorithm. First we will see how it will go. Relieving aortocaval compression. In this picture it is showing the one-handed and the double-handed method, how to manual displace the uterus to the left side in women above 20 weeks gestation. Below 20 weeks, the uterus is not occupying the whole abdomen. So above 20 weeks gestation, it will have a pressure or a weight on the inferior vena cava. Where uterus is palpable or at above the level of the umbilicus permits effective chest compression in supine position. We have to displace the uterus either by a single-handed method or by the double-handed method to relieve the inferior pressure or weight on the inferior vena cava. In another diagram, you can see the tilting of the spinal table or the bed of the patient. It is tilted 15 to 13 degrees towards the left side. You can also provide patient a bench if you have no table or there is no facility available to tilt the patient towards the left side. You can keep a pillow, blanket or some other thing to make the position like that. Circulation. This slide is showing how can one give the compression by putting both hands on the chest of the patient. We have to give the 30, initially it starts with 30 chest compression with 2 ventilations. Assess before chest compression, you have to ensure the patient is breathing normally. Turn the patient into the recover position. Check help is on the way. Assess breathing pattern. If there is no breathing, assess the breathing pattern of the patient. If there is no breathing, we have to provide patient the oxygen with the help of the this laryngeal mask. This is the laryngeal LMA, the airway for breathing. This is the laryngeal mask which can be inserted before the help arrive and patient is intubated. Mouth to mouth only if no airway adjuncts available. 2 attempts at ventilation to minimize interruption to chest compressions. If the patient is intubated, you can continue with chest compression 100 to 120 minutes, 100 to 120 per minutes. If there is no response, then attach defibrillator or assess the rhythm. If there is ventricular fibrillation or pulseless ventricular tachycardia, provide shock 120 to 220 joules with 360 joules monophasic. This 30 compression for 2 minutes after every 2 ventilation is continued for 2 months and assess the patient. Again assess the patient. If the patient is resuscitated, continue with this, and if there is no asystole or PEA, जिसे हम कहते हैं pulseless, again start immediate CPR. It's important to clear and protect the airway as early as possible. First is if there is no facility available, you can provide mouth-to-mouth breathing. But if the medical services are on way, you can give the patient laryngeal mask if the person is skilled enough to give. Otherwise, you have to intubate your patient with a cuff endotracheal tube. Endotracheal tube insertion should be performed by skilled person with supplemental high flow oxygen. Bag and mask ventilation insertion of a simple supraglottic airway should be undertaken until intubation can be achieved. This is a bag and mask, is the laryngeal mask. Supplemental oxygen should be added with a glass flow of 10 to 15 liters per minute to whatever method of ventilation is used. High flow oxygen should be provided to the patient. If airway is clear and there is no breathing, chest compression should be provided immediately. If there is no circulation, you have to provide IV fluids to the patient by giving to IV large bore cannula like 14 or 16. You can provide patient fluid through other routes like venous cut down या intraosseous है और CVP line, central venous line. Central venous line. If patients needs fluid, so it's better to take the above the diaphragm lines like jugular vein, right subclavian vein, or internal. Goes to volume replacement, but cautiously in patients like pre-eclamptic or eclamptic patients. These patients are prone to develop pulmonary edema. The defibrillation energy level should be used as a non-pregnant movement. Initially, 30 chest compression at a rate of 100 to 120 per minute should be performed for every 2 ventilation breaths. Once intubation is achieved, the ratio of chest compression to ventilation rate should be synchronized. Ventilation should be provided at a rate of 10 beats per minute with continuous chest compression, 100 to 120 breaths per minute. Usually, the chest compression is not effective after 20 weeks of gestation because of the huge gravid uterus. So, it's better if the patient is not resuscitated, there is no response within 4 minutes, it is better to proceed for the delivery of the fetus and placenta and consider about the perimortem cesarean section. Consideration should be given to the cause of the collapse throughout the resuscitation process. Resuscitation effort should be continued until a decision is taken by a consultant obstetrician anesthetist to discontinue. But because the brain death occurred in 5 minutes, we have to decide about the perimortem cesarean section within 4 minutes. Decision should be made in consensus with the cardiac arrest team. Perimortem cesarean section. In women over 20 weeks gestation, if no response occurred to correctly perform CPR within 4 minutes of maternal collapse, or if the resuscitation continued beyond this, then the perimortem cesarean section should be undertaken. Perimortem cesarean section should not be delayed or performed where maternal collapse has occurred, should not be delayed. Where the maternal collapse has occurred, it doesn't matter. You have to perform the perimortem cesarean section within 4 minutes, either through the midline vertical incision or the meniscal incision or the suprapubic incision. The choice depends on the person who are skilled in taking the baby out or which incision provide the more rapid access. The cardiac arrest team usually comprises of the senior staff with appropriate experience and the persons are skilled. Senior midwife, senior obstetrician, anesthetist, in addition to general arrest team. Educatedly skilled team with appropriate equipment should supervise transfer. Transfer to a high dependency or critical care area with appropriate staff and monitoring facilities. New adult team antepartum collapse occur after 22 weeks gestation. Proper documentation is essential in all cases whether or not the resuscitation is successful. Incident reporting and debriefing of the woman, the family, and the staff involved in the event, and the training of the medical staff or the doctors. After the event, the post-collapse management depends on the patient is alive or dead. If the patient is alive, continued treatment of the underlying cause of the collapse, transfer to appropriate clinical care settings, high dependency or critical care unit of the patient is ensure the proper documentation, debriefing of the patient if the patient is alive or the family members, offer staff the support and debriefing about the incident. Is there any flaws or is there any there's any need of improvement so we can meet, months can meet. Review the case through clinical governance process or by the clinical meetings. If the patient is not alive, then inform the coroner or the procurator. This is basically the maternal collapse algorithm, and that we have to follow this algorithm. Just like if the patient comes with maternal collapse, we have to treat the patient by the BLS and the ACLS, the basic life support and the advanced cardiac life support. The BLS, the basic life support includes the airway, the circulation, chest compression, and the defibrillator. And the advanced cardiac life support include all these with the treatment or the treatment of the cause which leads to maternal collapse. If you have any question.
तो बहुत दिक्कत